Welcome to the Crossroads of Health and Hunger webinar hosted by U.S. Hunger, formerly Feeding Children Everywhere. I'm Rick Whitted, the CEO, and joining me today on this panel are leaders in their field, but also partners in our mission and stakeholders in the evolution of our organization and programs. So help me welcome each of them. I'll start with Dr. Shelley Dennis. Dr. Dennis is the faculty chair of health sciences and sustainability at Rio Salado College. She is an MD and PhD who focuses on issues of food inequality in our food systems that call for policy response. Dr. Dennis, good to have you with us.
Thank you so much for inviting me to be part of this panel. I'm really excited about the conversation.
Glad to have you. Next, we have Dr. Bahia Maroon. Dr. Maroon is the CEO of Polis Institute, an applied research institute, an anthropologist by training and practice. She is passionate about deploying social science to create solutions that result in a more compassionate and equitable world. I will add that Dr. Maroon, we call her around here our dignity coach and self-worth guru. She has been a big help and inspiration to our organization as we have attempted to operationalize dignity throughout our programs. Dr. Maroon, it's good to have you.
Thank you so much for having me. I'm looking forward to the conversation.
And lastly, we have James Lewis. James is the owner of Paragon 7 Studios and Consulting Group, which has the core competencies of influencing healthcare media and assisting managed care plans with their strategic approach to Medicare, Medicaid products. James has more than 2 decades of health provider and health plan experience with a keen eye on social determinants of health. He's also a radio personality. James, it's good to have you a part of the discussion today as well. And I will tell you on the front end, as we were doing run of show, James is having a little bit of technical difficulty, so you may see him in and out. We will go with the flow. James, good to have you on.
Thank you for having me, Rick. It's my pleasure.
Absolutely. For those, let me give you a little background on U.S. Hunger. We are a 501c3 impact organization whose mission is feeding families today and uniting them to a healthier tomorrow. Many might know us as a meal packing events group, but with COVID, that changed. And in 2020, when the world shut down, we had to shut down all of our events. And we woke up one morning with 90% of all of our revenue gone. So it forced us to think quite seriously about our impact. And so we turned to our Full Cart program, a nationwide contactless food delivery program, delivering shelf-stable meals, and we would later evolve in last year to delivering fresh produce, 10 to 12 pounds of fresh cold produce directly to the front door of families and seniors in need. While we lost income, our empathy and desire to solve hunger only grew, and we converted to a national virtual food bank model. We invested in technology, focused on data and client engagement, all for one purpose: to understand a question that embarrassingly now we realize we hadn't really asked or paid attention to in a decade. Why are they hungry in the first place? And to do that, we had to ask questions. More importantly, we had to listen to their stories.
What would happen in crisis if we took the time to listen?
A full cart box will help my father and I greatly. As a recent cancer survivor, I am in continued treatments every 3 weeks, so nutrition and vitamins are of the utmost importance. Also, with living rural and having no markets in town, this gift of a full cart box will be very much appreciated.
Our food supplies have dwindled over the past few months. I have suffered from diabetes for over 14 years and require healthy foods including proteins, fruits, and vegetables to maintain proper blood glucose levels. A full cart box will help to alleviate our food insecurity and to provide a healthy diet for our family. Thank you, and may God bless you.
Life changed when I was diagnosed with pulmonary arterial hypertension, a chronic and progressive disease that affects the heart and lungs. The inability to work due to poor health, combined with mounting medical costs, have made obtaining nutritious meals difficult. A full cart box will help provide food security. Thank you so much for all you do.
I lost my job due to COVID-19, and we would appreciate the help to fill the financial gap during the crisis for our family. My daughter was in the hospital recently for a severe reaction to her medication to treat lupus. We need help to have the food necessary for proper nutrition. Fresh fruits and vegetables are so important to maintain good health and to reduce the flare-ups of the chronic health conditions in our household members.
We're listening. We're learning. We're responding. At US Hunger, we engage every client to have deeper conversations and gain a fuller understanding of the socio-economic factors that determine health. Dignity and discretion are the foundational principles behind our work, and we believe everyone deserves a quality experience that says, you are worth it. To learn more, visit ushunger.org today.
So what you just saw was a dramatization of actual stories that we see and read about around here at US Hunger on a daily basis. And this changed our approach from simply feeding to really using food as a form of connection and gaining understanding and actionable insight. This happened because we started asking questions, and now with more than 60,000 survey verbatims, we realized that we were really taking a symptoms approach and not addressing the root causes of hunger. So let's start with this conversation around the role of a person's story. So panelists, this will be for each of you from your perspectives. How should we use a person's story to drive outcomes and construct sustainable solutions? And what role does dignity play in that? Dr. Bahia, I'd love to start with you, particularly from the perspective of community programs and social services.
Well, at Polis Institute, Polis has over 10 years of community engaged storytelling experience. And we really encourage nonprofit organizations and community leaders to focus on what we call data with dignity, storytelling with dignity. And it means listening to the way in which people narrate their life experience. It means understanding the value of the story that's being provided to you. So very often in lower income communities in particular, your life story bears what we call a biographic currency. So if you are a middle income person, an upper income person, your biography belongs to you. You do not have to trade your biography for goods and services. When you're a lower income person, your currency, you're not able to provide those dollars. So when you're filling out the forms for healthcare services, for food services, for after school services that are lower costing, when you're filling out all of those forms, you're trading your biography for services. And what we encourage nonprofit leaders to understand is the weight of being an individual who's constantly being asked to trade their biography to receive a service. And so we suggest that organizations find ways to put a reciprocity into that circle of storytelling. And so it's not just gathering what the organization might need to hear in order to understand how to deliver their services or create a series of reports. It's ensuring that the way in which people tell you their story becomes represented in the solutions that you create. And I think that that's part of what is so compelling about the transition that US Hunger has been making. And what I love in the storytelling snapshot you gave is, we're listening, I'm listening. And that's what's so important when you're collecting those stories, is that it's done in a way that signals we're listening for the way that you tell your story. We're creating solutions, based on the narratives that you are providing.
Well, I will do it again publicly and live. So much of that is in part to a huge gift I got as a new CEO here, which was having about an hour dialogue with you, and really stressing the importance of conveying self-worth in every touch, whether it's client experience, et cetera. It has been transformational. So I'd encourage anyone who's looking for that to connect with Polis Institute for sure. Thank you, Dr. Bahia. Dr. Dennis, same question. A person's story and how does that drive outcomes and sustainable solutions, but from the perspective of food inequities in our food systems?
Yeah, so what I want to emphasize really is that hearing people's stories does a little bit of myth busting, and it really challenges a worldview that makes the problem more sustainable than the solution. We live in a system that reduces people to economic units, individual economic units. We matter for our dollars. That's what makes us important. And as a result of, first of all, one could question whether this is a good view of a human. We are the product of either 15 billion years of evolution or divine creation. And either way, possibly people could be viewed as more than mere dollars. But as a result of this worldview, we focus more on individual decision making than we do on the context in which decisions are made. And we don't affirm the right of all people to have healthy food. So in that context, we tend to focus on individual decision making in a way that also blames people for their lack of food. So when we talk about the poor or people of color, we blame obesity on bad food choices and sedentary lifestyles, as compared to when we talk about middle class or upper class people or white people, in which case about only 30% of articles mention personal choice. So we tend to blame people for their own problems rather than looking at these bigger systems. But when we hear someone's story, we get a bigger picture. We start to see the context in which those decisions are being made. We see that people don't have access to fresh, healthy food. We see that healthcare problems are draining their resources and they're not able financially to afford fresh, healthy food. We hear that they don't have transportation to a grocery store. We hear that they're on foot and they have to walk to a store where the prices for produce are astronomically high, or there may not be fresh produce available. And when we hear that story and we get a sense of those bigger interconnecting systems, we can respond to a person's needs more holistically and as a result, more humanely.
Yeah, that theme of dignity rings really true. James, same question, but really from your perspective of gaps in our healthcare for medically underserved communities, the role of a person's story and how dignity fits into that.
Sure, it's very important to look at a person's story, what I would employ in the network construct. Just like Dr. Dennis and Dr. Maroon mentioned experiences that they've drawn from the way that healthcare networks are constructed to make sure that individuals have access not just to good food, but to care. Are you able to get a mammography or a colorectal screening in your zip code? If you have diabetes, do you have access to a nephrologist, an endocrinologist, cardiology, all of the services that you need to stay healthy? One of the things that I'm excited about this mission, Rick, is really merging the importance of eliminating food deserts and identifying those who are food insufficient and overlapping them with people that have serious healthcare gaps, because there's really one and the same. It's the same perspective of looking at people as units of production. Being able to really look at the panorama and the importance of having viable services and viable food, all of those things go together on the healthcare continuum. So like Dr. Maroon mentioned, we have people, when you neglect those issues, there are downstream repercussions. Dr. Dennis mentioned that we often demonize individuals that don't eat right. We demonize people that have serious health, chronic conditions. But the truth of the matter is that it is our responsibility as leaders in healthcare and leaders in delivering food and mental health, social determinants of health programs. It's our responsibility to push on provider groups and large payers and hospital systems to ensure that the infrastructure is there so that regardless of what side of town you live on, what side of the tracks you live on, you have someone in a poor urban area or poor rural area should have the same access to good food, clean water, and healthcare as someone that's in an affluent area.
Yeah, it seems to always come down to accessibility, regardless of the need. It's some form of access issue. Let me go to the second question, and thank you each for the first. When you listen, you learn about the person, which is why we started with story. And though we provided more than 120,000 homes across the U.S. With food, what we found is that the story is usually not about food. And so out of more than 60,000 verbatims, and this is literally just pulling words out of stories, we see words that correlate with 68% of that population living in food deserts, 31%, roughly 20,000 dealing with some form of economic instability. Healthcare access is about 20% of the population. Neighborhood and physical environment, it's really a misnomer. You need to take the 5% and the 68% and put them together. It's about 73% as it relates to neighborhood. So Dr. Dennis, let me start with you here. Based on those population data points I just shared, I've heard you say, show me your zip code and I'll show you how healthy you are. Can you elaborate on the disparities of our food system? And then second, the health impacts that those disparities create?
Yes, I can. So the disparities really come in the form of what you're already calling food deserts, which are areas where people lack access to affordable, healthy food. And this happens through a dynamic in which quite often large chain big box stores are able to drive out most of the other competition, and then they themselves pull back from the areas, leaving people with little access to fresh, healthy, affordable food. And in poor neighborhoods, we see that there are about 4 times fewer supermarkets and about 3 times more places to drink alcohol than there are in middle income and upper class neighborhoods. There's furthermore less access to green spaces, parks, recreational facilities, health clubs. And where there are even some supermarkets, the supermarkets in those neighborhoods tend to charge more for the fresh produce in those low access neighborhoods than they do in a middle income neighborhood. So people who have income limitations are being asked to pay more for the same product. And if we're talking about the working poor, we're also talking about people who have heavy commute times, who are often working 2 to 3 jobs, and they begin relying on very cheap fast food to fill their gaps. They need to eat on the way from one job to another. So we're talking about a situation where the options available to a person tend to be unhealthy, and they're selecting from bad options. There aren't good options really accessible or available. And all of this combined, the reduced access to fresh produce, excessive availability of high calorie foods, sedentary lifestyle because you're driving from one job to another and you don't have a playground or a park, results in what we call metabolic syndrome. And that's a situation where people have high blood glucose, high blood pressure, obesity, especially around the midsection, and high cholesterol. And that's a risk factor for heart disease, diabetes, and strokes. So it immediately trends people towards a higher rate of health problems. And we can begin to add cancer into this mix as well, because many cancers are being linked to unhealthy diets. To add insult to injury, if you live in a food desert, you likely also live someplace where you can't get access to healthcare. So it's really hard for you to get your healthcare needs taken care of. Being sick reduces your ability to earn an income, as you've heard in some of the stories that you shared on your video, and you further have a decreased ability to pay for food. So it all sort of spirals down in a pretty negative way. Also, in food deserts, we have limited access to education, and we know there's a correlation between educational attainment and health outcomes. So a food desert is not just a place where people have limited access to food. It's a place where there are limited accesses to everything. And in the food movement, these days, we're changing our way of referring to these areas from food deserts. We're now calling it food apartheid, because we want to emphasize that this situation is the result of decision making. This isn't an accident. It's not inevitable. It's not the result of forces beyond our control. These are decisions that get made at large policy level and smaller levels. For example, the reason that there are so many fast food chains in poorer areas has to do with a decision in the 70s to promote small business development by funding franchise fast food restaurants without really asking if that was really what people wanted to do with their lives, whether there would be something they would rather be doing instead. That was what was funded. And those decisions can be made differently. And so one of the key points about this conversation, if I can get no other point across, is that these structures result from decisions, and we can decide otherwise collectively. We can do this. We can fix these problems. They feel big, but we can solve them together.
It's so interesting to hear. It's almost scary how, as you talked about the metabolic condition, how those string of diseases align with our the top self-reported diseases we see. James, let me jump to you. What current measures are health plans and providers taking to improve this clear accessibility to health resources gap that Dr. Dennis mentioned? And are they the right measures? And if not, what are the right measures?
I think that traditionally healthcare providers have been focused on the HEDIS measures and the STAR measures that are used by CMS, especially in the government space. So you have risk adjustment programs, which measures an individual's risk score at a 1 equilibrium, meaning that someone with a 3 risk score requires 3 times the spend and 3 times the healthcare needs. And then you have the STAR ratings that are actually quantitative, based on how many breast cancer screenings did you get, how many flu shots did you get, things along those lines. What healthcare providers are doing to get a little bit more sophisticated, they're using those analytics and starting to get into predictive analytics. Just like Dr. Dennis said, if you have the trifecta, the obesity, the high blood pressure, the high blood glucose, you know that downstream there are going to be cardiac issues, neurological issues. So health plans are really looking at the data, and they're starting to look in advance and be able to ascertain what's going to happen with a member beforehand. I think that health plans are in the right space doing that. Where they're not in the right space, they need to look a little bit underneath the surface and partner with groups like US Hunger that can not only say that, hey, we know that on the medical record, a member presents with a myriad of illnesses because we have the ICD-10 codes, we have the HCCs for those that are in healthcare, the hierarchical condition categories, we have the HCPCS codes, all of those things, but really move the focus a little bit lower into what's going on at the granularity, what's going on at the zip code level. How do we know that in zip code A, we have 100 diabetics that keep their A1C at 6.5, but then 3 miles away in zip code B, we have 100 diabetics, their A1C is 10.5, and they're having complications with their kidneys, eyes, neuropathy, things like that. So I think that the final frontier and what COVID has kind of pushed, we need to partner up. We can't do this in silos. We have to have feet on the street. We have to have organizations that aren't necessarily clinically based, but have the same goals in mind to keep people healthy and to maximize health outcomes, maximize nutrition, maximize exercise. I think that what Dr. Dennis said was right on point. How can you exercise if you're in a neighborhood that doesn't have any green space? And that's by design. Out in suburban communities, there are parks everywhere. There's places for people to play soccer. places for people to go running, places for people to go hiking. But you go into some of these urban or really rural communities, they don't have the same access. So all of that should be brought together under similar umbrellas, bringing people from the healthcare organizations to people like yourself, Rick, to other people that are really focused on social determinants of health programs, and really combine to create an overarching strategy that benefits everybody.
It's well said, James. Thank you. Thank you so much for the insight. Again, I see that theme of accessibility there. Dr. Maroon, let me come to you, and I want to kind of leave this broad for you. So the data we showed, the discussion we're having, how does this inform you? And what are the larger data trends you're seeing out there as it relates to these communities and populations that we're talking about?
Well, another way to think about data trends is to talk about telling the truth about causes. And so a data trend we've seen for a very long time is to use misnomers to talk about the problems. And so all of the people participating today will be familiar with terms like cycles of crime, cycles of poverty, generational poverty, right? We're all familiar with these words. The reality is that if you ask a person in a low income neighborhood whether or not they feel like they're part of a cycle of crime, or they feel like they're part of a cycle of generational poverty, they're going to look at you like you really definitely do not come from their neighborhood and probably shouldn't be talking to them. To use an honest language of equity, we can tell because we're using words that the people they apply to would never apply to themselves. So the first thing that we all want to start acclimating ourselves to is telling the truth about the problems. And the truth of the problems that we look at when we're talking about social determinants of health, the reality that a person's zip code can currently predict their life expectancy. When we're talking about that, what we're really talking about is a cycle of oppression, right? And when you say to someone, how do you overcome a cycle of oppression? Then you're telling them, you're signaling, you know what the solution is. The solution is resilience. The solution is liberation. And what we're starting to see on the ground are what we're calling networks of resilience. And I'll give you a very brief example. So a network of resilience operates like this. In a given community, this is a true story, but in deference to people's privacy, I'm not going to name the particular community. In the community, we have peer health mentors. What do we know about that? The data tells us that when you look like me and you come from my background and you have the same health condition and we're peers, there's a much higher likelihood that I'm going to follow my health plan. There's a much higher likelihood that I'm going to have positive outcomes for managing my diabetes, my hypertension. So we start with people-based solutions, peer health mentors. And then we look at something like a local farmers market. We have a community leader. He said, you know what? We need to have a local farmers market right here in this so-called low-income neighborhood. That farmers market is a place where people come, they meet, they talk, and they do more than just buy their produce. They share stories with one another. They share hope, resilience, and inspiration with each other. So the next step of that is that when the box from U.S. Hunger arrives and it's full of fresh produce, they heard a story at the farmer's market last week about a new recipe on how they might prepare that food in a box. And this is what we mean when we talk about networks of resilience, where we're saying it's people on the ground who solve the problems. It's institutions like U.S. Hunger that provide some of the tools. It's local leaders like the gentleman who started the farmers market. It's institutions that support the peer health mentors. And it's people at the local level leading the charge. That's how we overcome cycles of oppression and turn them into networks of resilience.
I love the comment, keeping it real, Dr. Maroon. I love that. Thank you so much. And so, audience, as you guys can clearly see why these three partners of ours were our start to coming out of the gate with this discussion. Let me turn to, and I want to mention one of the things I really love, Dr. Bahia, about your approach. We've stolen it, so I give you all the credit, at least the first two times, is the way Polis does its research. It's actually community-based. You work with folks in the community to gather that data in very much the same way. It's why, although we've been feeding people a long time, it's the uniting them to a healthier tomorrow evolution. That is simply because we talk to them, we engage them, and we listen to what they tell us. And though not easy or inexpensive, we had to figure out how to get a cold box of fresh produce that has leafy greens and fruits and vegetables directly to their front door, because the trend said that's what they needed based on what they were dealing with. That leads me to the final question here. And just really quickly, and I want to leave some time for Q&A. So audience, if you've got questions, I see a very active chat going on. Feel free to shoot questions in as well. And we're going to leave a lot of open Q&A time here for this panelist to tackle some of those. So there's an overlap in our population data. So 76% of our families and individuals we help are saying that they have chronic illnesses. 68% of that same population are showing up on our GeoMap in a food desert. So clearly there's a connection to hunger and health. That's why we're having this discussion today. Let me start with you, Dr. Dennis. When you look at that overlap, talk about the concept of food as medicine. And I've heard you often talk about and write about the importance of micronutrients to the body. So food is medicine. Talk about that.
Yeah, so food is medicine. So first let's talk about what is a micronutrient. Besides being a long word, what is it? It's a nutrient that we need in really teeny tiny amounts, like micrograms of vitamin B as compared to grams of protein per day. So something you just need a little bit of it, but you need it. Your body doesn't function well without it. Those micronutrients serve as cofactors in processes like making your blood, making your immune system work, creating healthy tissues in your body. And we're seeing an increase in micronutrient deficiencies for two main reasons. One is inadequate intake. And as we've already discussed, in the situation of food deserts, that is precisely the problem. People don't have access to fresh produce, so they can't choose to eat it if it isn't there to eat. And the other reason that we're seeing a decrease in people's intake in micronutrients is that our food is less nutritious than it used to be. About 20 years ago, even, somebody by the name of Donald Davis at the University of Texas did a nutritional analysis of food available at the time in the late 90s and compared it to food available in the 1950s. And he showed that 6 out of 13 micronutrients had decreased in food. So food had less of the micronutrient in it. And the reason for this has everything to do with how we farm. We select varieties of foods that will grow faster, but they can't necessarily take in that nutrition as quickly as they can grow the size. So they're never going to be as nutritious. And our soil is largely depleted of nutrients because we farm using artificial fertilizers to get our food to grow faster without adding complex nutrients to the soil. And what we're also finding in this situation is these micronutrient deficiencies affect your metabolism such that, and it also makes it more likely that a person will have insulin resistance. So people who live in food deserts who don't have access to produce are going to be short in some micronutrients, and as a result are going to be more likely to have metabolic syndrome because the food that they do consume doesn't contain the micronutrients. And as we talked about above, having poor health is going to lead to low income, and having low income makes it so much more likely. It makes it twice as likely that you'll live in a food desert. The leading causes of living in a food desert: number one, poverty; number two, being a person of color; number three, not having finished high school. Those are the top three causes of living in a food desert. And so you can see how this, as we're talking about this cycle of oppression, people live in places where they are prevented from having access to resources, which then has a negative outcome on their lives. And then we blame them for the outcome without recognizing that there are structural reasons why they don't have access to those resources. And it is about developing resistance. And Dr. Maroon, I'm so happy that you raised those issues as clearly as you did, because that is absolutely 100% what needs to happen. And Rick, I want to just give you a huge shout out for giving boxes of fresh produce to people in need. That is what we see not happening in much of the supplemental nutrition system, is they're not getting fresh produce.
We have a great team, and we have great partners, and we let the families inform us. Dr. Maroon, let's hit the other side of that coin. So those are the impacts and challenges of the food deficiencies or insufficiencies. What are the not so obvious effects or other social determinants that are impacting these households?
Well, one of the challenges that folks have is putting together all the pieces of this story to really grasp the gravity of impact. So when we talk about a household where someone has a chronic illness like diabetes or like asthma, we're talking about a household that's spending 5 times more on healthcare than a household where there isn't a member who has chronic illness. So you take that, you've got a higher spending cost, and then you add that to there's a much greater likelihood that their employment outcomes are severely depressed. What do I mean by that? I mean that if you're the person taking care of the person with a chronic illness, how much more difference and impact is that going to make on your career track, for example, if you're trying to go for those promotions, for those add values? If you're the person with the chronic illness, what kind of an impact, again, does that have on your educational track, on your career track? And then this employment situation is going to obviously decrease your income situation. So now you've got all of these compounding factors. And when we look at the people who are suffering the greatest disproportionate effects of chronic illness, what we see is that African Americans are at probably about 1.4 times more likely to have a chronic illness. American indigenous persons, Alaskan natives, are up to 3 times more likely. You take asthma, you're looking at 14% versus 10% in these populations. So when we start adding race, class, employability, healthcare expenditure, what we see is this absolutely devastating complex of what we can again refer to as a cycle of oppression. And going back to some of the comments that James has made, what really starts to come across is that healthcare is a justice issue. Healthcare is an equal rights issue, right? And all of these pieces, food access, healthcare access, these are justice issues, and they're justice issues that have to be overcome if we're intending to start to actually overcome cycles of oppression that cause poverty, that cause elevated levels of chronic illness, elevated levels of malnutrition. We overcome those cycles of oppression, their impacts, by getting to the root source and creating systemic justice through networks of resilience.
That's so well said. I'm thinking of a comment that I heard my board chair make a while ago. He said, Rick, food insecurity and hunger is just unjust. It's unjust. And you really elaborated and nailed that well. Hey, James, let me turn to you here. So from 2020 to 2021, our population data showed that chronic illnesses self-reported last year were roughly 63%. Year to date, that's about 10,000 applicants year to date. It's 76%. So it seems to suggest that COVID has had a negative impact on those food insecure households. What has COVID revealed about the gaps in healthcare, in our healthcare system? And put your quality and risk lens on here. I'd love to get your take on that. I've heard you talk about this quite a bit.
Well, I think it's the same as the other ladies on this panel have mentioned, Dr. Bahia, Dr. Dennis, is that it's systematic. What COVID actually shows, COVID has spread light on something that people that are in the know, like Dr. Dennis and Dr. Bahia, who study this for a living, have known for 15, 20 years. It's just now we've seen that the weakest among us, meaning the poorest among us, those who struggle, can impact those who are in affluent areas. If you're standing next to someone at a Walmart that doesn't have the same healthcare opportunities that you do, if they have COVID, you can get infected with COVID from them. So I think it's caused healthcare leaders to really deconstruct everything that they do. CMS is moving into more of a telehealth space. Once upon a time, you really couldn't get telehealth in government markets unless you're in an extremely rural area. So the federal government, CMS, healthcare leaders they spent a lot of last year scrambling to look at their strategy and to look at how they're going to construct their network, to look at how are they going to build their delivery models over the next 5 to 7 years, because COVID has blown up everything that we've done historically. Going back to what I said before, it's just important that groups like U.S. Hunger and other leaders really press and use the relationships they have with healthcare leadership and experts from a quality and risk management STARS standpoint to implore to these C-suite leaders who create the networks, who hire the endocrinologists, who hire the anesthesiology groups, to say that we can't make these decisions without involving other entities that are not clinical per se, not necessarily people who are patient care advocates, but healthcare and wellness concierge. I love what Dr. Bahia said about having actual coaches that contact people. We know that if you have a peer, if you're a diabetic or if you have hypertension and you're talking to a peer that is going through the same thing, that is taking metformin, that's taking insulin, that's gone on the up and down crisis, that's been in the ER because they've had high blood sugar, that's had to go to the courses where they really learn how to eat and how to cook properly, you're going to have better outcomes. So I like to say, Rick, when I talk to you, teamwork makes the dream work. You have to have, if you just have it done in a silo where it's the health plan and the hospital drawing this playbook up by themselves, you're not going to have the maximum results. You have to bring in specialists that really understand what's going on in the community at the granular level with wellness, with nutrition, with mental health, which is a huge issue that's often overlooked in health plans, and to get a comprehensive coalition, so to speak, of people that are all swimming in the same direction, looking to have the same results, and providing consultancy. Health plans should be looking to the Dr. Maroons and the Dr. Dennises of the world for consultancy when they're constructing that network and when they're rolling out their benefit plans moving into next year and beyond.
Thanks, James, and thanks to all the panelists. We've got a few questions coming in now. We have very little time. I'm going to take a stab at a couple of these, throw them out, and I promise keep your questions coming in. The panelists have agreed that they will address them. I saw a question earlier on the common misconceptions of food. Let me just take a quick stab at that, or of hunger. It's not about food. That's the biggest misconception. I wasn't even aware of that. I would have spouted off stats on how many we fed, how many meals we provided, and the 53 countries we've sent food to, and I never asked the question, why were they hungry in the first place? And once you start listening and allowing what every successful brand knows, your client will tell you who you are. So if you listen to the people you're helping, they will tell you what they need and who you need to be. So the common misconception is that it's not about food. Food is not the solution. We spend $100 billion in food assistance in our government. If it were the solution, it should be solved based on food and money. It's not. And you heard that in this discussion. Another question was, and I'll throw it out to the group, what role does technology play in these determinants? I'll open that up to anyone for a quick response, and we're going to have to leave it at that.
I feel like, James, that's your wheelhouse.
Okay. I would say that technology is really the true piece that links this together. And most, one of the things about when I decided to really work with Rick and just be a Hunger hero, they have a fantastic technology platform that can identify food deserts. And if you go into the healthcare space and arena, they also have technology platforms that can identify where there are gaps that to be closed and where there are insufficiencies within the network construct. Technology helps to bring all of this information together and overlap it. Once again, we as the people in the clinical side, I can tell you already what zip codes at any plan that I've worked on where there's going to be bad diabetic outcomes and bad hypertension outcomes and people aren't going to get screenings. But by adding technologies for platforms like US Hunger and social determinants of health, I can get much deeper beneath the surface. Like Rick said, hunger is not what drives this issue. It's the why. And technology platforms and really bringing teams together and overlapping multiple streams of data and using the statistical analysis, that helps us to find out, why is someone non-compliant? Why is someone hungry? Why is someone having issues within mental health? And then, like Dr. Bahia said, you can identify oppressive systems, and then you can start to backtrack and build towards fixing those and creating a resistance.
And with that, we are going to have to wrap it up. We're about a minute over. This will not be the last of a number of discussions. Let me close by, first of all, saying thank you to our panelists. And my thanks goes much deeper than this discussion. While we were partially informed by our clients, we are an organization that listens to those who invest in us, time, money, or whatever it is. These partners on the line have been huge pourers into our who we are and what we are becoming. So thank you each for being a part of this discussion, more importantly, a part of US Hungers and the lives of those that we impact. Thank you so much. Secondly, thanks to those that are listening. I know we have over 140 folks out there. I've seen some live discussions. Please keep it going. We'd love to hear more from you on any of our social media platforms. And if you want to talk to us or partner with us, whether you're a health plan or health provider, and as we're working with James, understand how Full Card is a quality and risk platform, or if you're a food bank or food rescue peer or partner out there, we'd love to talk with you around how we can partner with technology and data, or governments trying to get fresh produce to rural communities or urban communities, and organizational partners that might be looking for an employee engagement packing event or our virtual pantries. We welcome all questions. Please visit us or email us at partner@ushunger.org. And thank you all for helping us feed families today and unite them to a healthier tomorrow. Thank you all.
Thank you.